My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm a professor of radiation oncology, where I'm chief of the cardiothoracic radiation oncology service, and as well as director of clinical trials. Patients with small cell lung cancer have an exceptionally high incidence in the development of brain metastases in their lifetime. This has been shown time and again in multiple clinical trials. Without therapy to the brain, patients have an excess of a 50 to 70% chance of developing brain metastases. Worse, oftentimes that can happen in the setting of having reasonable extracranial control, such that they are more likely to develop the neurologic complications of brain metastases than they are to die of their other systemic disease. One of the earliest attempts to try and minimize this risk was the use of prophylactic cranial radiation. Prophylactic cranial radiation is just whole brain radiation, often given at a slightly lower dose. And we've seen in those initial trials that prophylactic cranial radiation unambiguously reduces the risk of brain metastases. Now, it's not magic. We know that it's not preventing the brain from being seeded from new brain metastases. What it's effectively doing is getting rid of the micrometastatic disease burden that you cannot see on even modern imaging. It's possible that with increased improvements in imaging and perhaps other biomarkers that we may be able to better select those patients at the highest risk of developing that disease and therefore really stratify who may benefit. But at present, we don't have that. What we do have is data from modern trials run in a population where we use modern brain MRI imaging instead of CT that suggests that while the reduction in brain metastases remains clear and is proven in those trials, there is no obvious significant impact on overall survival. Now, that really shouldn't come as much of a surprise to us at this point because overall survival is largely driven by someone's extracranial disease burden. Most people don't die of their neurologic disease from brain metastases. However, my hope is that with future analyses of these clinical trials, we may be able to identify those patients at the highest risk of developing those complications of brain progression and therefore direct the therapy to those patients. The reason to avoid prophylactic cranial radiation is the same reason to consider avoiding it for whole brain radiation in patients with known brain metastases from non-small cell lung cancer. There are neurologic risks to PCI. Those include issues with short-term memory and recall, and possibly later deficits in other cognitive function as well. So there is a benefit to avoiding it when possible, so long as you're not subjecting that patient to an excessive risk of then progressing with neurologic deficits from future brain metastases. At present, in limited stage small cell lung cancer, while the trials are old at this point, and I think old is relative, but while those trials clearly demonstrate that there was a reduction in brain mets and a small improvement in overall survival. However, that's now being repeated in a modern era with modern MRI brain imaging in a subsequent study called Maverick, which is comparing PCI to no PCI, meaning close observation in patients with small cell lung cancer. In the extensive stage setting, it's even more ambiguous how to handle those patients. With extensive stage disease, historically, their outcomes were even poorer, but an analysis years ago demonstrated that there was a benefit in reduction in brain metastases and possibly a small survival advantage that wasn't expected through the addition of prophylactic cranial radiation, particularly when combining it with thoracic radiation. However, again, with modern brain imaging, improvements in disease control with systemic therapy options such as checkpoint inhibitors, which also have an independent effect in brain disease, this question needs to be answered again. In our institution, very few patients get PCI for extensive stage small cell lung cancer. It's a discussion we have, but particularly those patients who receive checkpoint inhibition such as atezolizumab, where PCI was not given on that trial, we often do not give it. For limited stage small cell lung cancer, however, we strongly encourage those patients to participate in the ongoing trial comparing PCI to no PCI, so we can definitively answer this question in this patient population.